Without further ado, I want to invite Dr. Gary Kaplan to the stage. Let's give him a round of applause.
Thank you, DJ, and good morning. Very much appreciate the invitation to be here, the opportunity to share a bit about our work at Virginia Mason. We have long prided ourselves in our relationship with the people of Alaska. So personally, every opportunity I get to come up to your beautiful state, I like to take advantage of, and the opportunity to partner with you and your patients has been an important tradition for us at Virginia Mason over decades now. As I think about what DJ was saying in terms of the introduction, and as I share with you some of the work we're doing at Virginia Mason, if I wanted to think about perhaps the last 20 years at Virginia Mason, it's really about taking action to make the rhetoric around value come true. And so it's not just paying lip service to the notion of higher quality and lower costs, but really making it happen. And so what we chose to talk about today was an aspect of that work that is helping us deliver higher quality, safer care, but at a lower cost. Because that obligation that DJ talked about in terms of being wise stewards of our community resources has never been more important. Never been more important, I think, in our community, and I suspect it's never been more important in your communities in the state of Alaska. Just a quick look at a couple of things that drive us. My colleagues from Virginia Mason see this several times every day. If you visited us, I suspect you've seen this. This is what we call our strategic plan. In reality, it's a strategic framework that helps us define who we are. And it was first developed in the year 2000, 2001. I was privileged to be, at that time, a new CEO, and our board asked us, who's your customer? Now, like everybody in healthcare, we said it was the patient. And I suspect if I asked you that question, that's what you would say. But what happened next was really startling to me. The board said, well, time out. If that were the case, why do things look the way they do? And in fact, as we began to step back and do a deep dive on our processes, we realized they were all designed around us, the doctors, the nurses, everybody who worked in healthcare. And the example I often use are waiting rooms. What are waiting rooms but places that we spend millions of dollars on in this country to create these giant spaces so patients can hurry up and be on time and then wait for us. It's kind of the antithesis of designing processes around our patients. Now, we still have waiting rooms at Virginia Mason, but we are working on building new clinics without waiting rooms because we believe that we can actually see our patients in flow. So that was really important almost 20 years ago as we began to think about how we needed to change many of the existing paradigms in healthcare. Our vision. Now, this might sound like apple pie and motherhood, but the vision to be the quality leader. That took many months to actually say, what do we aspire to be as an organization? Do we aspire to be giant, to control market share? You know, growing market share is not a bad thing, but was that our reason for being? And we said, no, our reason for being is to drive ever harder on quality. And so that's been kind of the defining true north for us. How do we design care around our patients, and how do we ensure the very, very highest quality? Now, in the original strategic plan, we did not have a base. You can see this base here. And that's when we went looking for a management system. And many of you know this about us, but today we're the longest added of anybody in healthcare, deliberately applying a management system to help us improve quality, patient experience, and lower cost. And that's what we call the Virginia Mason Production System, which is our application of the Toyota production system to healthcare. Now, if we wanted to be the quality leader, we needed to define what we meant by quality, because 15 years ago or more ago, people were saying, well, what is quality? And some were saying it's like that old definition of you know it when you see it kind of thing. But we said, no, we really need to be much more granular about what is quality, and came up with this quality equation. Now, it's not rocket science. It's, everybody knows value is quality over cost. But we said we need to take this a step deeper. So the O is for outcomes, of course, technical outcomes, but also functional outcomes. And I'll talk more about this. Did the patient get back to work? Did the patient get back to recreation? Did the patient get back to the things that were important to them? Also important beyond our assessment of technical outcomes. Service, the patient experience. How did patients feel in our care? Many patients today assume technical quality, and what's most important to them is how did I feel when I was in your care? Service. The W for waste used to be a C for cost. And those of you who work in healthcare delivery systems, and probably any other business related to healthcare, have experienced this. Well, it's now budget season, and I need every department to take 2% out of your budget, and I don't care how you do it, just take it out. But we know that that may often be a recipe for reductions in quality. And so what we've said is, and what we've learned, is that if we take out waste, the things that add no value, then we will improve quality and simultaneously lower cost. That the pathway to higher quality, safer care, better patient experience, and for that matter, a better staff experience, can be the same pathway to lower cost. But as I think about this now, 15 years later, then, as now, we are still predominantly a fee-for-service delivery system, albeit heavily discounted fee-for-service. Appropriateness, the A, was critical. So even in a fee-for-service world, we said, we can do a great procedure, we can have a great outcome, we can delight the patient and family with with a great experience, we can do it efficiently with no waste, but if the patient didn't need it, there's no quality there. And estimates are that upwards of a third of what we do in healthcare, and I'm very, very proud of American medicine, but I also know we need to be better. Up to a third of what we do adds no value. And so, as we think about this, appropriateness has been critical to our definition of quality. And part of the challenge has been how do we take that then to the marketplace and create a business model that helps leverage that focus on appropriateness. Now, before we did any of this work, before we discovered the Toyota production system, we also knew we needed to change the conversation. And that conversation was with our doctors. I came to Virginia Mason a long time ago, 40 years ago, as an internal medicine intern, and it was a really sweet deal, what I would call the old compact, which is still alive and well in much of American medicine. Entitlement, protection, and autonomy. I joined a group practice with insurance contracts, a good reputation, so I was entitled to patients. I was protected by the business managers, the people that helped us run our business, and the physician leaders like I became, and I was autonomous. Only I knew what was best for my patients. That did not sync up so well with teamwork, collaboration, electronic health records, skill task alignment. And so our frontline doctors went through a process of creating a new physician compact, which is still alive and foundational to what we do today. What does every doctor have every right to expect from the organization, and what does the organization have every right to expect from its doctors? So a new vision, a new strategic plan, a new physician compact, which went on to be the beginnings of a leadership compact and even a board compact, which were just transparent agreements and reciprocal understandings, and then a new management system. So, how do we take all of that investment over 15 to 20 years and translate that into a business model. One of the ways we're doing that is with bundled care. We've been doing this now for several years. It's increasingly of interest to the broader cross-section of employers and health plans, those buying care, but also to patients and how they get their care. How many of you are engaged in some sort of bundle work today? Anybody? The Medicare Bundle Payment Project is just off the ground. It's been successful in its first a couple of years, but we've taken that far beyond Medicare. So what are bundles? I'll talk about that and why are they here. How have we embraced bundle care arrangements at Virginia Mason? And how can potentially other organizations also embrace bundles? I think to understand bundles, you have to go back to what are some of the barriers that we face in our industry. So I would say that there's three major barriers to healthcare affordability. And you can see them here: lack of transparency, predictable price, and accountability. In terms of transparency, quality and price, not to mention cost, are under the table. We do not make those things visible to our patients and frankly to our employers. If you're a company like REI in Seattle and you're working with a broker and a health plan, what you see is your spend next year will go up, whether it's 8%, 15%, some as high as 20%. That's what you know. Your aggregate spend is going up. But within that aggregate spend are contracts with different providers at varying rates. You may be actually supporting a variation in quality and cost without even knowing it. The end users, the patients who have a lot more skin in the game than they used to have great difficulty understanding their costs and what the impact on them as individuals. And so transparency is critically important. And it's something we've stood behind at Virginia Mason now for many years and have helped our state begin the workings of an all-payer claims database, which will help us be even more transparent. Predictable price. Surprise to patients when they find out their bills. I suspect your patients, people in this community have had similar, maybe some of you have had similar experiences. You know, I had no idea I was going to get this avalanche of bills, or I didn't know that where I went for my care was out of network. Nobody told me. And what we know is that the attempt to be predictable is often trumped by the complexity or additional things that are ordered, a lot of often unnecessary tests and unnecessary treatments. So predictability is critically important. So transparency and predictability are both attributes that are embedded in successful bundle programs. And finally, accountability. When I realized this, it kind of drove me nuts, that we actually did better. We made more money if our patients had complications. I mean, it just makes no sense. That is not right. And so, as you see here, accountability. This little cartoon, you know, there's a 50% chance you won't survive the procedure, but don't worry, I get paid anyway. I mean, how obscene. And talk about stewardship of resources and our role as professionals. And so, we need to change that. And in Virginia Mason, bundles are one way we're doing that. You may have heard a couple of years back we announced our warranty program for our total joints. Basically, all that was really saying is we're standing behind what we do, and we're not going to have perverse incentives that reward us when bad things happen to patients. And so transparency, predictability, and accountability. Now, DJ's heard me talk about this before. One of the things that is very disturbing, and I apologize to those of you who've said this before. Actually, I said it before a long time ago till I realized that I wasn't proud to be saying it, is this two-canoe analogy, or one foot on the dock and one foot in the boat. And it goes something like this. Woe is us. We have one foot in the pay-for-volume canoe, one foot in the pay-for-value canoe. We don't know what to do. We're living in a world of ambiguity, and we just don't know which way to go forward, which way to design our systems. And basically, what that's saying is that until you pay us differently, we're going to keep ordering unnecessary tests, unnecessary surgery, because of the way the incentives are aligned. I think that's the antithesis of being a professional. And so, as we think about that, and as we think about the world we're living in, and even in a fee-for-service environment, and perhaps during the Q&A, we can talk a little bit more about that, we can stay focused on doing the right thing. We can stay focused on creating value. So what are bundles? Bundles are clinically defined standard episodes of care where providers, and that includes physicians and caregivers, hospitals, rehab, providers across the continuum receive a fixed reimbursement for all related services during the episode. Typically, it includes a warranty, and what a warranty really is that it's going to cover avoidable complications, readmissions, things that basically occur during the post-procedure period. We believe bundles can lower direct costs, and the biggest way it does that is by eliminating those unnecessary surgeries, unnecessary testing, unsafe procedures, and it can lower indirect costs by getting people back to work sooner. Many employers tell us that the cost of indirect impact of absenteeism and presenteeism are as significant or greater than the cost of direct care delivery to their workforce and their ability to not miss a step in the delivery of whatever it is they do. So bundles are all about transparency, predictability, and accountability. These are some of the areas where we're engaged in bundles. The state of Washington put out an RFP for hip and knee replacement for all state employees, and they're the biggest employer in the state. 13 or 14 systems responded. They foreshadowed they would choose 3 or 4, and after the site visits, they only chose us. And we were proud of that, of course, but what it really was about a system of care that I had a conversation with one of my colleague CEOs in the community, and he said, I don't know why they just chose you. We gave them a package price, but it was about a lot more than package price. It was actually about transparency and predictability and accountability. These are some of the other areas, and we're working on more as we go. To actually effectively put a bundle in place and then to understand how to sell it or make it accessible to employers and subsequently patients, you need 3 parties engaged. You need the provider. The provider's focus is on appropriateness, evidence-based care, the best practice, handoffs to the home sites, and we're now seeing patients from all over the US coming for our bundle through Fortune 100 employers. Employers, they need to be willing to say, as some large employers are increasingly saying, that we will incent you to go to places where we know the quality, the appropriateness, and predictability and accountability exists. And then finally, a third-party administrator. And health plans have not traditionally been all that welcoming of bundles because it doesn't sync up with their existing legacy systems. I think they're changing their mind a little bit, which is a good thing. But there are third-party administrators that we've worked with who are very focused on making that connection between the employer and the provider. We are looking to bundles as another way amongst many to continuously improve. So we are constantly revisiting each of these steps along the way. Appropriateness, critically important. So we have a complex spine bundle that now is one of only 2 or 3 centers in the country that Walmart, based in Bentonville, Arkansas, has chosen for their employees. They heavily incent those employees to use their centers of excellence for complex spine. Why? The reason is, the biggest reason is that of 100 patients sent to Virginia Mason for complex spine surgery, told in their community, you need spine surgery, complex spine surgery, and we can do it next week, 58% of those patients are sent home with no surgery. And only 1% of those subsequently have surgery. That's an eye-opener. That's huge. And believe me, you do not want to have spine surgery if you don't need spine surgery. But those patients had never had a trial of conservative therapy. They never had shared decision-making. They never had the things that actually help them find less risky and better options for them. Fitness for surgery, that's the second component. Do they meet our criteria? They have to have specific radiographic findings to justify a total knee replacement. And that's critically important. They have to have a BMI that is acceptable and places them in an acceptable risk category. Evidence-based surgery in terms of the surgery itself and the rehab, and then rapid return to function, which is critically important. So I mentioned some of these results under appropriateness, fitness for surgery. We know that the complication rate is much lower if the patients meet the criteria. And that's something patients want to know. Really, I have to do this, I have to actually stop smoking in order to take me into a lower risk category. That's important. That's patient-centered. That's going to drive towards a better outcome. Evidence-based surgery, how do we approach surgery? These are critically important. And we have and stand by the data around these opportunities for us. And then rapid return to function. What was really interesting is that we got 100 on a 100-point scale from patients who've gone through these programs. I didn't believe the data because who checks 100% all the time? But it meant that we were actually working hard to meet these patients' needs and importantly, and I think important to you, getting them back home as quickly as possible. And that's critically important, that they be home where their primary care physicians are, where their social support is, and that's also part of this work for us. So, keys to success in this work, commitment from all the parties involved, strong champions. We've got champions in every one of the service lines where this work's going on, and a mindset that isn't, a zero-sum game, that isn't me against you or we, they. That's how do we collaborate? How do we do the best thing for our patients and ultimately our community? And that's what I'm so excited about, opportunities with many people in this region and in the state of Alaska. Because for us, it's always been about collaborating in a way that adds value for patients, but also for the providers and for those across the community that depend on us. So thank you. I continue to think about things like this. It's not all about us. It's about what the customers, what the patients, what the families and communities get out of their healthcare system. I think it syncs up very well with this social contract that DJ talked about and how important this conversation is about how can we collectively help create a better healthcare system. That's what we're working on, and we hope to work together with you on this. DJ, thank you.
Thank you. Let me ask you, Dr. Kaplan, first thank you for sponsoring this conference.
It's our pleasure.
Let me just ask you, why are you here? Why is Virginia Mason sponsoring state reform, and why have you made the effort to come to Alaska? I think I know the effort, but I just thought I'd ask you directly so you could speak to the vision.
We are not an organization that, as I said earlier, that is a giant multi-hospital mega system that wants to, that believes in just using our market power. We're actually an organization that thrives on collaboration, thrives on partnership, thrives on relationships. And so I know that's what you're about at State of Reform, that's bringing people together across the industry, multi-sectors like we have in the audience today. And so this was a great opportunity for us to be part of a conversation and hopefully help advance the conversation ultimately on behalf of our patients and communities. And then, as I said earlier, we have great traditions with the state of Alaska. And I'm not sure if it was in part wanting to take shopping trips down to, Nordstrom, and there was only one flagship store, but somehow we've built some relationships that we continue to highly value and over decades, and we want those relationships to continue and thrive.
Yeah. I think the sort of idea that the compact has changed and that the role of physicians, formerly as kind of an autonomous caregiver, now as part of a team.
Right.
I think that has been adopted and accepted across the spectrum by different parts of the healthcare spectrum. Some are more collaborative than others.
Sure.
And you found some collaborators here in Alaska in varying ways. I think Vera is an entity that VM has been engaged with over the years, and others. Maybe speak to what collaboration looks like in Alaska with VM, based in Seattle, with partners here on the ground.
Well, as I said earlier, and shared with some colleagues last night, I think patients, I'm a primary care internist, and I still see patients. And what I know is that patients do best when they're close to home, when they're with their loved ones and their care providers that they can trust. And so that's a really important aspect of our attitude, our approach to partnering in Alaska. We want people to stay here. But when they need to come, when they need to leave their community for care, for things that aren't available here, then I think what we want to be about is efficient, seamless, high quality care at the lowest possible cost and the best patient experience, and then all importantly, rapid return to function, rapid return to their home communities, where I think people do much better. They heal faster, they thrive in their own communities. So that's kind of the foundation of the partnership. And then I think it's how do you play to everybody's strengths, and how can we help in that regard. We don't have the corner on expertise. There are many things that patients can get extremely well in this community, but as a tertiary referral center, we want to be available, and we want to find ways to partner and collaborate. And then ultimately, it's about creating win-wins. It's not about advantaging Virginia Mason, or as I called it last night, that great big sucking sound to Seattle. That's not what we're about. We're about finding ways to collaborate that make sense to everyone.
Yeah. What would your counsel be? I love this question because it's sort of a window into their leadership and their style, and kind of honing down all of their years of experience. So no pressure. But to this group, what would your counsel be to these senior healthcare executives and health policy leaders who are trying to navigate a tumultuous time politically, a fraught time in the marketplace? What advice do you give them?
Well, I think there's two attributes of strong leaders that I think about that apply over time, but are particularly important at inflection points. And I think we're at an inflection point. Not sure what's on the other side of it, and I think that's part of the nature of why this is such a challenging time. Unprecedented ambiguity and uncertainty in the healthcare industry in our future, how we'll get paid, et cetera. But those two attributes are curiosity and humility. And so I would encourage leaders in multiple sectors to be curious about what they don't know, and curious about what we can discover. And that, I think, leads to new relationships, partnerships, synergies that we could only imagine or maybe didn't even imagine. And then humility is something I've had to learn. I mean, I'm proud of Virginia Mason. I'm proud of what we've been able to do, but we're not perfect. I mean, we've got so many opportunities to keep getting better. And I think if we have that mindset, as opposed to, I've been doing this 40 years and take it from me, here's what we need to do, that's not going to advance the ball where it needs to go. And then probably the last thing is stay focused on the why. Why are we in healthcare? Why did we choose to become physicians or whatever sectors we represent in the audience? Why did we take this industry? There's easier ways to make money. You probably know this. There's
I'm in
easier
the conference
ways
business.
to,
I don't know, apparently not. I don't.
but we chose healthcare for a reason. And I think all too often we forget what that reason is. So it's one of the things we talk a lot about. Why did we become physicians? Why did we become nurses? Why did we become healthcare administrators when there was a whole lot of other businesses we could be working in? And I think it's because we want to make a difference for our communities. So staying focused on that, I think more often than not, is going to lead us to the right answer.
Curiosity, humility, and focus on the why. Dr. Gary Kaplan, Chairman of Virginia Mason, thank you, sir, for being here. I appreciate it. Let's give him a round of applause.
Thank you. Thank you. Appreciate it. Thank you.